Sexual Medicine Committee for this unique initiative where we discuss the case studies and the extract we extract the things from in clinic experiences. So this is such a unique initiative from Sexual Medicine Committee. And to run the today's show, we have very lively and dynamic experts as a moderators. I welcome Dr. Seema Sharma, Senior Consultant and Sexual Medicine Specialist, and Dr. Apurva, who is a Public Relation in charge of Sexual Medicine Committee, FOXI. So without taking much time, I would like to hand over the stage to Dr. Seema. Madam, please take the charge and proceed further. Over to you, madam.
Good evening, everybody. Thank you, Mr. Desai, for welcoming everybody. And I, on behalf of the Sexual Medicine Committee, FOXI, welcome all of you for this wonderful webinar and initiative by Dr. Neeraj and his team. I'm part of his team, yes, but really my admiration for Dr. Neeraj grows every time, we present a new webinar like this. So today we are going to be talking about genital pelvic pain, which is quite commonly encountered by gynecologists. It causes a lot of distress to a woman, and when she says that she has she has pain on sexual intercourse, gynecologists are many times in wondering what to do about it. So today we will have our experts with us to answer all your queries, and we are going to have a case-based discussion. So over to my co-moderator, Dr. Apurva, who will now start welcoming our chief guest, and Dr. Neeraj. Dr. Apurva, please.
Thank you. Thank you so much, Seema ma'am. It was my really a great privilege to welcome none other than but a person behind all this webinar, a person behind every webinars which we are doing, and who actually bring the sexual medicine committee in that level where everybody, it is a talk of a town, the program by the sexual medicine committee. And thank you. It's my privilege to welcome none other than chairperson of our committee, Neeraj Yadav sir. Sir, everyone know is a past president and secretary Rajkot Obese Society, at present chairperson of Sexual Medicine Committee, and vice president Rajkot Menopause Society. Over to you, Neeraj sir, to give a brief introduction about the program.
Rohit, we can have a FOXI theme video before I start the program. Can we have?
Rohit, please play the video.
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOXI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation, and it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan, and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience, and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dheera, to stop violence against women. Foxy for all, always. We strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Tira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dheera, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Tira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
Thank you, Rohit. So, good evening and welcome to this third session of the C2C series, that is Confusion to Consensus series, and greetings from the Sexual Medicine Committee, Foxy. As rightly pointed out by Shanta Kumari Madam, we as an obstetrician have a much larger role in the health of our woman. And when we talk about the health, how can we forget about the sexual health? As Madam mentioned, we are the first point of contact with our patients. So they can easily share their problem with us and we can guide them better about their problem. So we must know about the sexual health issue. Earlier, we did masterclass series with the 6 sessions. After finishing it, we realized that we need something from the practical point of view. We may be knowing topic very well, but when patient come to us, we may find it difficult how to approach and how to manage this patient. So we started this series, Confusion to Consensus. We choose single topic and present different case scenario to our expert, how they will approach such case and how will they manage and monitor this patient. This is our third session of the series. Earlier we did female sexual interest arousal disorder and second was on female orgasmic disorder. So today we will cover GPPPD, that is genitopelvic pain or penetration disorder, which is a combined in the DSM-5. Two categories, two dysfunction are combined. Vaginismus as well as dyspareunia are now combined in this new category. I hope you will find this session useful in your day-to-day practice. Keep connected to us for various academic activities by Sexual Medicine Committee. You can join our Facebook group and we have also our Facebook page, Sexual Medicine Committee. You can search it and join it to keep yourself updated about our activities. So welcome once again to Happy Learning and thank you on behalf of Sexual Medicine Committee. Over to you, Apurva.
Thank you so much, Neeraj sir. That was really, really wonderful. And now it is it's my proud privilege to introduce our chief guest, Dr. P.K. Shah sir from Mumbai. He has developed this thing about being a teacher par excellence and a very strict taskmaster. Sir has been our Foxy past president in 2012, and ever since he has held many prestigious positions. So he's been president of ISAR and IH, and of course many publications to his credit. So thank you so much, sir, for joining us, and we are waiting to hear a few words from you, sir.
Thank you, Seema. I was not the president of ISAR, but Foxy, IAG, and other organizations. Anyhow, at the outset, let me thank Foxy, Dr. Shanta, Dr. Madhuri Patel, Dr. Vipin Pandit for having me here today as a chief guest. And obviously, I must thank Dr. Neeraj Yadav, who is the chairman of Foxy's Sexual Medicine Committee, for giving me this opportunity to be with you all in the evening on 30th December, probably the last webinar of the year, I hope. Confusion to consensus. I think that itself is something very important and very attractive for anyone to join. It's something I feel that in our lives, lots of problems happen. But when it comes to sexual problems, we feel ashamed to talk to anyone, even to our family members, to our friends. So the only people whom a person can go and talk to is a doctor, and especially a gynecologist. So I'm so proud to see that Neeraj has made use of this COVID time to give us knowledge on different aspects of sexual problems in everybody's life. Majority of people have something or the other related to sex, sometime or the other in life. And I'm so happy. I was an active part of few programs in past conducted by Dr. Neeraj. I was thoroughly impressed by the selection of speakers, thoroughly impressed. And it is not that just because we are MBBS, we are taught everything about sex. So you require a very concentrated efforts on the part of the sexologist or the specialist in the field to give you complete knowledge about the sexual problems and its solution. Very important. So today we are going to talk on case discussion on genital pelvic pain and penetration disorders. And I believe the speaker is none other than Dr. Padmini Prasad and two young Turks from Foxy, Dr. Seema Sharma and Dr. Aburo Kumar Datta. They are going to moderate. Let me tell you, both of you, that when we were of your age, we were never invited as moderator. We were invited either as chairperson or at the most as panelist, not even as a speaker. So we feel great to see that such young people, the second line of defense of Foxy, has taken up in a big way this challenge, and they are going to moderate this particular discussion. So all the very best to both of you. And I hope we have a very scintillating evening related to sex problems. Thank you very much for having me. And Neeraj, I request you to allow me to leave at around 7 o'clock because tomorrow is my wife's birthday and none of the hotels are available tomorrow. So we are celebrating it today. So thanks a lot and wish you all the very best, Neeraj, for all your future activities. Thank you.
Thank you. Thank you, sir.
Thank you, sir.
Thank you so much, PK sir, for giving us the blessings, and we always delightful and really gratitude towards you because you are always there and bless us. Thank you so much, sir, for your kind words, and a very happy birthday from all of us from Sexual Medicine Committee to ma'am, and wish you a very happy New Year.
Thank you.
Waiting for party at the indoor.
Yes, sir, definitely.
Yeah, my birthday is on 1st.
Wow.
Yes. Very nice.
So it's really my privilege to invite none other than the guest of honor for today, I can say the one of the most charming Foxian, and he's not only the most charming by his look, he's much more charming by his heart. He's like a great friend. He's like a great, mentor. He's like a great guide to me. Thank you so much, Parag sir. Everybody know you, sir is past secretary of the ICOG, and really, भाई लोग अगर जानते हैं आईसीओजी के बारे में, अगर people are talk about ICOG, it's due to the Parag sir, because he brings ICOG to each and every society. Sir, thank you so much for giving us the time. Thank you so much for giving the blessing. Over to you, Parag sir, for your blessings.
Thank you, Apurva, for those sweet words. Good evening, all.
Parag, before you
Yes,
speak,
sir.
I want to add something to what Apurva said. Most sought after man in our Foxy.
Yeah, definitely, sir.
All right. Good evening. First of all, apologies. I'm in the OT, so I cannot take out my mask and cap. I need to wash up in a short while. First of all, thank you, Foxy, especially Dr. Neeraj Jadhav, for having me as a guest of honor and allowing me to sit virtually next to Dr. PK Shah, who's a very dear friend. Though he's very senior, he has always been very close. I remember way back in 2002, as secretaries of Mumbai and Pune Society, we did have a wonderful conference at Lonavala, and which was an instant hit. So thank you, Dr. PK Shah, sir, for always being there for me. When Neeraj asked me to be part of this committee, it took me back in 2010. And of course, Dr. PK Shah was the Secretary General then, when we had a lot of brainstorming in the Foxy Managing Committee, and then two new committees, or rather three new committees were born. One was sexual medicine, endometriosis, and the third was urogynecology. And when you look at the decade of sexual medicine committee, Neeraj, I must compliment you for doing excellent work, and which you are doing even in COVID times, reaching out to people with so many details of a problem which is not talked so much about. I remember one of my senior colleagues in Pune did call me repeatedly because he was not getting a link, and Neeraj was very helpful in sharing the link, because the doctor who's nearing 60, she was very much interested in learning all the aspects of sexual medicine. And she very rightly pointed out that when we were students, we were never taught these things. So it is a great learning experience for even all of us, because many years ago when we did our PG, we were not taught all these things. So my best wishes for the program, and I'm happy to say that ICOG has granted 1 credit point for today's program, and Neeraj, do continue performing so well in the field of sexual medicine. Thank you very much.
Thank you, Parag.
Thank you so much for your kind words, Parag sir, and for giving your precious time. Over to you, Seema ma'am, to introduce none other than but the faculty for today, our own Padmini ma'am.
Yes, thank you, Parag sir, for being there for us. And again, my really proud privilege to introduce Padmini ma'am. And I always tell her that I'm in awe of her. She's been the president of Bangalore OBGYN, and she's the national coordinator for the Sexual Medicine Committee, Foxy. And she's perhaps the only certified sexologist and an OBGYN that I know of, possibly in our country. And we really look forward to hearing expert comments from you, ma'am. So really welcome being here with us, and hope to clear a lot of doubts that people have while treating such patients. So before we begin, we had decided to kind of clarify on the topic that we're going to talk about. So ma'am, if you would permit me, I would just share a few slides here.
Before that, I am extremely thankful to you all for this opportunity. I feel it is an honor for me to be a speaker or a faculty for this. Thank you very much, Dr. Seema, for those kind words about me. Thank you, the guests of honor of today. Thank you, Dr. Neeraj. Congratulations for doing such great work. and spreading knowledge and creating awareness among all gynecologists, which is a must, which I think the gynecology and sexual medicine is the best combination I can tell you, because you get to see the whole couple, you get to see the woman, the whole family, the husband, everything. So it becomes easier for you to treat the problem and also give the quality of life to the whole family. So that is the great combination of gynecology and sexology. Thank you very much for the opportunity. Yeah, you
We
can.
also need to learn a lot of patience from you. So with your permission, ma'am, can I start the slides?
Sure.
So good evening, everybody, once again, and we are going to be talking about the genitopelvic pain and penetration disorders. So first is the definition of what constitutes the whole paradigm of pelvic pain. So it is defined by DSM-5 as vulvovaginal or pelvic pain that is provoked or exacerbated by sexual contact. And this pain should last for at least 6 months, and it should cause distress in a woman. And this pain can be, the pain perception that a woman has can be, before the penetration, can be during penetration, can be after penetration. It can be in the vulva, it can be in the vagina, perineum, pelvic areas, anywhere. Essentially, for gynecologists, we can consider this as an umbrella term. It comprises of two main broad categories. One is dyspareunia, which is like the painful penetration, and vaginismus. And a word about dyspareunia. Dyspareunia is basically a recurrent pain with sexual intercourse. This causes distress in a woman, and it can be divided into two types. Either it's superficial and deep. So we can ask, when a woman says there is a pain, we can ask her, where is the pain? Is it only at the entry? That means it is either at the vulva or vagina. Mostly superficial dyspareunia is because of dryness, less estrogens, vulvodynia, skin disorders, surgeries. And then the second category is the deep dyspareunia, which is associated with deep penetration. The penetration in the beginning is all right, but when there is deep penetration, there could be in the deeper part of vagina or lower pelvis, there could be pain. So if there is a deep dyspareunia, then the differential diagnosis is essentially either endometriosis or some surgery or a PID or, organic issues. It can also be divided into primary when it has always been there. When, something has been inserted into vagina, the patient feels pain. She has difficulty having a tampon insertion, she has difficulty having a digital examination, she has difficulty having a penetration. And other category is secondary dyspareunia, where pain begins after some time of pain-free sexual activity. And of course, it has to be differentiated from vaginismus, which is involuntary contraction of pelvic muscles. The patient just closes her thigh and they essentially feels there is a wall and the penis can't go through. So this is vaginismus, and this is not under patient's control. So please be gentle to the patient and do not keep saying it's like all in your head, and if you can relax, you should relax. It is everybody can do it. Why you can't do it? There is no problem. So this is an involuntary contraction. Important thing is, friends, that let's be not judgmental to women, and try and identify the cause and treat the patient accordingly, because timely intervention can really save a family from breakup. A lot of emotional distress can be saved, a lot of physical distress can be saved. So this was about our topic. Over to Dr. Purva now for the first scenario, and I would request Dr. Padmini ma'am to share her inputs on the case.
Thank you so much, Seema ma'am. As ma'am has already stated, that many times the main problem, which even all of you, because when there is any sexual problem, people are not getting to the doctors. Actually, they are searching in the in the net. They are asking their peers group, they are asking their friends who are equally knowledgeable, and they are searching in the internet, and it is full of misinformation, wrong information, and unfiltered information. So it's a very important to give a clear-cut message and to give a clear-cut treatment to these type of patient. So this is our case one. These all are actually the live case. So Padmini, to you, a 20-year-old unmarried girl come to the gynae OPD with a complaint that she and her fiance have tried to get intimate, but were not able to do so on many occasions due to too much pain. They claim to be comfortable with each other, and pain is there even after use of the lubricant. So, question to you, ma'am, what should be our next step?
See, at the first instance, what happened?
Ma'am, I just wanted to add, on her physical examination, it was found that the orifice is small and she is uncomfortable with even with a little finger insertion. So what you will advise, and is there a treatment? Is a physical problem or it is only psychological? Yeah, over to you, ma'am.
Yeah, thank you, Apurva, for that opportunity and a nice case. See, in this case, what all things suddenly comes to your mind? Number one, she is a young girl. Number two, she is an unmarried girl, and she has got a fiancé. And she has got, according to your examination, a tight hymen probably. So before we go to that, first take a detailed history, because this is one thing what we have to learn is that, because as soon as you think that she is an unmarried girl and she is having a premarital relationship, so you think that she is doing something wrong. So any sexologist, one thing has to keep in mind is that we are not imposing any morals, our morals onto the person. Whatever problem the client has come to you, immaterial, it is whether immaterial of the age, marital status, or sexual orientation, or any ethnic origin, or whether married or unmarried, immaterial of all that thing, you have to tackle that problem and counsel and give treatment for whatever the client has come. So that is one thing which we have to keep in mind. So the next thing is that take a detailed history. So what is causing the pain, and whether then she has got any other infections, the all causes, so many things which were enumerated by Dr. Seema. So all those things, whether there are any other rule out, a system of ruling out all the other problems. So whether she is comfortable with she says she is comfortable with the person. So there is no problem with the relationship between those two. And still she has got pain even after using lubricants. A clear-cut history she gives. Even then, a detailed sexual history. What I have seen when these young girls or the young the couple are with the partner, when they come, most of the time they are trying intercourse in a wrong position. If they are trying intercourse in a stretch leg position, so there will be pressure on the clitoris, on the mons pubis, and then the pressure above, that is causing the pain. They will not understand that it is a wrong position that they are trying. So when you are examining, this is another thing that you have to keep in mind, whether they are having in a proper position. In spite of having the sexual intercourse with the proper technique and with sufficient foreplay, and after she relaxes well, even then there is a pain for penetration. And now that after examination that you have found out there is a tight hymen. And again the question comes, an unmarried girl, if it is definitely a developmental problem and a tight hymen, are you going to do anything for that? Because she is not yet married, in case she is not going to marry the same person, then again her so many things will be there. Afterwards she will come, and if you do hymenectomy in an unmarried girl, I don't know whether any gynecologist or whether any of you have come across such a case. An unmarried girl, you know very well, when she asks and you examine, there is a tight hymen. There are so many ethical issues, moral, ethical, cultural issues associated with that. So that there also again the gynecologist will be in a dilemma. So for her, then you counsel her properly. So there is a developmental way. If everything else is okay and her only problem, the pain is because of the tight hymen, then you have to sit with her, sit with their fiancé. Are you going to get married? When are you going to get married? And if she is so many times, I got recently also, one girl, she came with their partner and she said, we are regularly having physical relationship, but somehow I am not able to cooperate with him, and then I want to see that he is happy, but we are unable to have intercourse. Then I asked her whether you are going to get married or no, that I can't say. But now that I want to solve my problem, that whatever that I have got, but I cannot say that I am going to get married to the same person. So openly she said. So then in that case, if you are going to treat this as a hymenectomy or anything, if she definitely needs only a small finger, little finger insertion that much here, you have to tell her these are what are the consequences. If you are going to correct it now, future you may be having problem. So you have to take a decision on this. At least you can just ask her to do some relaxation, self-dilatation and all that, that can be done. Even then the question comes whether there is hymen is broken and all that. Any amount of education, whether they are abroad, whether they are here, whether they are highly placed, that I have seen, it is very difficult to remove that deep-seated cultural idea that they have to have a proper intact hymen for the before the marriage. So that is always there, even whatever you say and whatever awareness you are going to give. So this is the pitch that we will have. So accordingly, counsel her properly and tell her this is the problem. And you, if there is a not a proper technique they are using, the counselor, educate them. And this may be the reason. So if there is anything else, because he clear cut, you have told that it is a tight hymen. These are all the issues which will come. Counsel her properly. If they are going to get married, then you tell them when the date is fixed, come before that, we can do the operation, or immediately after the marriage, we can do the operation. That's how you have to counsel in this. So this is a very difficult, you have selected a very good case where there will be so many dilemmas, even for the doctor, what to do for her. Whether we can help her by doing a hymenectomy and allowing them to have a proper intercourse, or leave it, counsel them, ask her to come before marriage or just after marriage. So this is the thing.
Yes, ma'am. I get a lot of cases in my OPD like that. But ma'am, would you like to try dilators for her
yeah, then you can tell that you can the self dilatation and then a slow dilatation. Sometimes the hymen they will have stretchable hymen. So with slow dilatation, I have seen, even I was thinking it is just one finger it is allowing. So she may need Fenton's operation. But when I asked her to do this dilatation, when she comes back next and it is easily allowing 2 fingers and a stretchable hymen. It can happen. Only that she can try. But any operation, then later you may get into problem if you just advise.
Madam, any role of Botox therapy in such cases?
No. There is no need to go into all such. Botox therapy will not correct the rigid developmental problem. No?
Yeah.
If it is vaginismus, that's a different issue. But if it is definitely the developmental problem, I don't think Botox is advisable.
Very rightly said, ma'am. What I feel in my OPD or what bottom line message should be, each and every case is like a different one.
Yes.
And we have to treat them according to that.
Yes.
It's not like the patient has pain, you are giving painkiller and the purpose is solved. Yes. The taking proper history, it should be, the treatment should be according to the goal oriented, according to the clients oriented, what they want. We can't generalize a same treatment to everybody. This is the bottom line.
So in theory, when you can say, you can list out so many treatments, so many things, but all that knowledge, then you can condense it to that particular person and individualizing. So that is really, that takes time. And as you go on seeing patients like that, automatically you develop that art.
Rightly said. So Seema ma'am, can we go to the next question? Over to you, ma'am.
Unmute yourself.
You are muted, Seema.
So sorry for that. My connection was a little weak in between. I got dropped out. So the second scenario is something similar. There is this young couple comes to your OPD, again, a very common scenario with being married for 2 years. They have been unable to consummate their marriage. Otherwise, they are socially and, in a good position. They want to start their family now. They are worried that people are now telling them to conceive, and then here they are who have not been able to consummate also. But when you examine that patient, she doesn't allow genital examination. She closes her thighs, even when you put your hands on the vaginal lips. And on history, she says she's never inserted her finger or even tampon inside. She doesn't even want to be touched. She says, I don't want to have sex. But okay, she, still would say okay for the sake of having children. So how do we go ahead for such cases, ma'am?
Yeah, this is married for 2 years, a clear-cut case of non-consummation of marriage. And from the history, you can at least think that there can be vaginismus.
Yes.
So according to your definition, this fits into that. Even then, sometimes what happens, as I told you, so the number one, you should look into whether they are having proper technique of interview. Most of the time, though they say that the history says that there is a problem, they cannot touch and all that, when you examine, actually that is an improper technique itself is causing the problem. But here, even for the examination, when she is not cooperative, so many they go on giving excuses. If you ask them, lie down, I want to do the examination, then she said, no, I am not clean, I have not washed, I have not shaved, and so they hesitate to undress themselves. So these are all indication that she may be suffering from vaginismus. And even during that is the best thing that you can do, history and physical examination. That is the gynec exam. They are the best things to know about the vaginismus. And history, even if you take the history from her, take the history from the couple, husband will be telling, no, so many times I have tried and no, I have, because I am so scared, and she gets pain and she screams and I cannot proceed further. And sometimes even if I forcibly I ask her to relax and do that, it is like hitting a wall. And these are all the things which can give clue that there can be vaginismus. So in that conditions, when with the history, it is suggestive from the husband, this is suggestive history. And when you do the gynec examination in vaginismus, that is the best thing that you can do. It is both where you can detect the cause, at the same time, you can give her the sexuality education and tell the proper technique and find out where is the problem, and then give the treatment for vaginismus also. So that I can explain to you. So first of all, you can rule out whether there is any other cause. Any reason for dyspareunia also can give rise to vaginismus. So rule out all the causes for dyspareunia also. And then like previous case, there can be developmental problems for which once there has been pain, and she thinks that, so that is reinforced in her brain that the mental mind is conditioned to expect pain each time. And in the history, it is also important to take whether she has got any negative attitude about sex, whether she is from a very orthodox family, or whether there was any child sexual abuse or any sexual abuse. And these are also important things, but because these are all some deep-seated things which you have to treat when you actually come to the treatment. It is not just a straightforward treatment of vaginismus, the associated things, but there will be so many times relationship problems. There can be fear of pain, fear of bleeding. This is a very common myth or the misconceptions what we have culturally. So they think that they have to have bleeding and pain. And some bad advisors from some elders and friends, that itself can trigger this. So this is most common the thing which is causing vaginismus. That's what I have found out. A friend is telling, I asked my friend and she said it's very painful and I really could not bear the pain. That one thing is enough. So I tell them, even if you cannot do good, at least don't do any harm by giving bad advices. Don't tell anything, but don't give bad advices. So this is a very common thing, and this is what will fix in their mind. And the brain thinks that anything, even the thought of any penetration itself, it will say, if there is any penetration, attempted penetration, so it will tell the pelvic muscles, keep off from it, you may get pain. So that is how it sends signals to pelvic floor muscles. And in vaginismus, there are three things. One is anxiety, fear, pelvic muscle spasm, and pain. Pain, fear, and spasm. These are the triad of vaginismus. So you have to tackle the pain, you have to tackle the fear, you have to tackle the pelvic floor muscle spasm. So accordingly, then when you rule out all the things, you have taken a good history, you have done the examination, utilize that aspect, that time only to tell her about her own genitalia. Ask her to look into the mirror, be comfortable about your own genitalia, and then go for desensitization. I will only give just a practical thing. I don't want to list out everything that is available because we are discussing practical points. How I treat my cases of vaginismus, and I have got almost 100% success in that. Some have got it cleared within 2 weeks. Some have taken 2-3 months, and only 2 patients have taken even about 1 year to come out of this vaginismus. So it depends whether it is mild, moderate, or severe type of vaginismus. I have also seen vaginismus cases. The moment even you go near her, her thighs start shaking and shivering. And this is a very severe form of vaginismus, and she will just not, she will just push your hand. She does not want to get examined. These are all severe cases. But at least some amount of the cases where she closes her thighs will not allow you to do that. Then start advising her how the first thing is she has to learn how she can relax her thighs, abdominal muscles. This is very, and vaginal muscles. That is a relaxation first. Understand what it is, that is like sexuality education, and then tell the technique. And for a proper penetration, she needs to have a proper position. Thighs flexed and extended, and then vagina, thighs are separated, then the vaginal muscle relaxed, then only she can have penetration. Otherwise, with closed thighs, she cannot have penetration. So that first thing she has to learn. So ask her to do the breathing exercises, take slow, deep breath, and then while releasing the breath, ask her to separate the thighs and keep it there for a few seconds. So she will slowly do that by taking deep breath, separating the thighs, and then do it at least 15 to 20 times, 3 times in a day. So slowly she knows how well she can relax her thighs, thigh muscles, and relax her vaginal muscles. Then comes to become comfortable about genital touching. So she has to keep her hand outside the introitus in the just to touch, keep there for 5 to 10 minutes. Daily do it 3 times in a day. So she starts becoming comfortable. So I have seen girls who are really scared to even wash themselves during when they take bath and wash it well. So that type of sensitivity for not being comfortable about the genital touch. So keep the finger outside vagina for 5 to 10 minutes, 3 times in a day. When she starts becoming comfortable, slowly insert your finger inside the vagina with 1 finger. Keep it there for 5-10 minutes, again 3 times. Then when with that comfort, when she is comfortable with 1 finger, start doing with 2 fingers. And slowly ask her to call her back every week and start assessing. Each time, give her moral support, reassure her, and tell her that you are improving, you are doing. And how well within 2 months, I'm sure most of these cases will come out of that. And in that, the partner participation. So when she starts becoming comfortable for vaginal penetration, ask the husband also to help her, and even if she can allow the finger penetration from the husband, that also can be allowed. When she is completely able to keep her thighs apart, relax herself, and able to keep 2 fingers inside, that is the time you should allow them to start the intercourse and find out. Give her good lubrication so that there is no friction or the pain even for that. And then tell the proper technique and allow her, tell the husband to give a proper foreplay so that she will have proper lubrication, then allow her for. So with this simple technique, I have not used any what so fashionable treatments or this, that. They have not received any anti-anxiety drugs or any injections, local anesthetics. And I always avoid anything with the local anesthesia, gel or injections, whatever it. I want her to have the sensation, not block the sensation. That's what I tell her. Because so many times she comes with lot of these local anesthetic gels, lidocaine, xylocaine gels. So that should not be done. You give her lubricants. even for her finger dilatation, give her the lubic gel and water soluble or KY jelly, and with that apply it, and then try with self dilatation. That is all is needed. And if she is comfortable now, sir, so many dilators are also available, and the dilators with increasing size you can give her, or the candles which you get, different sized candles, cover it with the condom, and then she can use it as the dilator also, different sized dilator. That itself will do that. There is no need for any fancy treatment, no need for any big costly dildos or dilators. If they want it, they can have it. Not that you should not advise. If they are interested, that also will act like a sex toy, and it will give her more stimulation. It may stimulate her desire also. Slowly you can increase that. When a large sized penny sized dildo she is capable of putting inside, then the intercourse can be allowed. And during that time, another thing which you can do is that, because of the vaginismus, long-standing, non-consummated marriage, husband will slowly develop some amount of decreased desire and secondary erectile dysfunction. So when you allow them to have intercourse, give some tablet to him also till they are okay, and till they start having regular intercourse. You can give small doses of sildenafil to him and then ask them to go in for that. So this is the best thing, though there are so many other very severe cases and other things can be tried. But in my experience, when I have seen so many cases of vaginismus, especially in being an ITBT capital, Bangalore being that, I have seen this vaginismus very common in highly educated, highly placed people, rather than the rural people. And so they expect something, and then, but I have seen few cases, but the incidence is very high among highly educated. Because what happens, they feel embarrassed and then shy, and then they cannot ask anybody about this. So they think they have to live with it, and there is no treatment, and how to ask the doctor, and how to go to the doctor, whom to tell. That is the main problem, that the treatment is available. So that you have to be aware of. Then I think with these simple things, most of the cases of vaginismus can be treated. Very severe cases, as I told you, very deep-seated, some cases with the sexual abuse who are undergone, repeatedly tell them, it is not your problem or your mistake that there was abuse. It is someone else's problem or someone else's mistake. So you don't have to feel guilty about it. So that is all. In that case, for example, quite a few child sexual abuse cases I have seen, where the teachers or the one who comes to the house to teach them children, or in the school or somewhere, if they have experienced that, so that they remember in the adult life. At that time, they will not have given so much importance, but in the adult life, sometimes they remember that, and then they start developing the problem. So you reassure that it is not your problem. You are not, I think I am cheating my husband, I feel bad, and so I am unable to. These are all the feelings which they get. But you can reassure them, remove the anxiety from their mind. So this is very severe cases, and sometimes some schizophrenic, psychiatric, those who are on psychiatric medication. So they also sometimes come. So along with their medication, with the psychiatrist help, you can also teach them about these exercises, relaxation exercises, self-dilatation, counseling, removing the anxiety, and these things will go a long way. And the other vaginal cones and these things are available. If they can afford, if they want to have such things, it is left to them. That's also again a similar graded like thing. Cones, they can keep it for 15 to 20 minutes each time there. So that is how you can treat.
Right.
Yes.
Very well said, ma'am. In fact, even I have noticed a lot of patients coming to my clinic. If we have a performer, and also when we ask, a lot of them, in fact, more than 3/4 of the patients would really say that they've had a childhood abuse, and they can't really talk to anybody, because most of the times it is either cousins or mamas or close relatives who are
Joint families, incest problem is very
Very
much
high.
there. Yes.
Yes, and whatever you may say, and a lot of times, patient would start crying while you're talking to them. It's like such a release for them because nobody has ever talked to them about it.
Yes, correct.
So it is very sad in our society that, it's everywhere, I think. But yeah, it is.
But repeatedly tell her it is not her fault, don't have to feel guilty, and you have to have the self-confidence and esteem. So many times that itself will, it's like boosting the morale for them.
Yes, ma'am. Yeah. Thank you so much, ma'am. So now Dr. Apurva will take the third scenario.
Ma'am, before taking the third question, I just want, in the previous questions, the Neeraj sir told about the Botox, because nowadays we already see a lot of advertisement regarding that. But what you have told very nicely, we are not using these fancy type of treatments. So what your experience in these type of cases for using Botox?
No,
Is there any role of it or
no,
not?
there can be role because people are treating that. That is only if you find that it is nowadays the vaginismus is also known as levator ani syndrome. So this is the levator ani syndrome is slowly replacing the term vaginismus. So many places now they are using that term. So if when you do the palpation, when you do the examination, you see that all those other apart from that, when you really palpate the levator ani muscle, you can see the tense muscle. So if there is a severe spasm of the muscle and that is predominant, those are the cases which can get the help from Botox, because that is like a muscle relaxant when they do give that, and that has to be done by a proper person who is trained in Botox injections, because when they give is one thing, they can develop urinary incontinence, they can develop fecal incontinence in the muscles, because when the sides of the vagina, when you are injecting into the muscles. So those are the muscles which are also acting as sphincters for urethra and rectum, anus. So that is one thing, a complication which can happen. And some of the studies, slowly that also may become a standard treatment. But any amount, any other treatment you give, that systematic desensitization by relaxation exercises, self-dilatation is a must. Any other treatment you give, that is my experience. Botox and other, but still it is not yet approved. All radio frequency things and vaginal thing, Botox, it is not yet approved by the FDA. Yeah. So they are trying, and so many studies are coming up, and especially Singapore and all, some urologists, once we had some discussion, he was also doing a lot of it. So what they do, they give Botox injection. They keep the vaginal cone smeared with the local anesthetic gel. And when the girl gets up from the anesthesia, so she can feel that there is been the size something there, which is there in the penetrating inside the vagina. So that becomes a desensitizing procedure, and it helps. Sometimes when I went to Singapore, they also rapid desensitization they were calling. So that's what under anesthesia, give anesthesia, relaxation, and when the penny sized, the maximum sized cone or some dildo, keep it inside, leave it there. And then when she gets up, that she knows that there has been something there inside the vagina, and help her to move it inside and in and out, so that she knows that it can go inside and it can come out without hurting her much. So repeatedly 2-3 days she has to start doing the dilatation. So that is how that also can cause desensitization. But sometimes the vaginismus is so severe, so easily they are not able to relax the muscles and then put that. Even the smallest vaginal dilator, they are scared to put. Their own fingers, they are scared to put. So slowly let them touch it, touch the genitalia, become comfortable, then start inserting that. And only see, there are the other cases where vaginismus and the tight hymen, they are coexistent. So if you do when you come to know that it's admitting only a tip of the finger and very tight, and sometimes it is impossible to do a vaginal examination and to assess the introitus, whether it is normal or whether it is tight or whatever it is. Unless the vaginismus is treated, sometimes you cannot assess the introitus. That is one thing. even if by asking her to relax milder forms of vaginismus, if you come across a tight hymen, so there is no point in doing, because so many cases have come to me, they have undergone hymenectomy, but the severe vaginismus is there. She says, I already undergone operation 2 years back, even then I am unable to do it. But she has got vaginismus. Without treating vaginismus, don't ever do hymenectomy. In such cases, you clear the vaginismus first, then do the hymenectomy, then that is very important. So then you can give her a good life or whatever. When she is able to relax, keep the thighs apart and keep the vaginal muscles relaxed, then do the hymenectomy. So these are the things where they can be coexisted. That's why the vaginismus and dyspareunia, they have combined. There will be some overlapping of symptoms over coexisting conditions. Dyspareunia can cause vaginismus. Vaginismus can cause dyspareunia. Sometimes it is difficult to diagnose. That is why they combined both in the DSM-5 classification.
Very rightly said, ma'am. So moving to our next scenario. Ma'am, it's a 32-year-old woman and her husband come to the OPD complaining of pain during sexual intimacy. The pain is so severe that they are unable to have penetrative sex. He has recently developed a baby vaginally 4 months back. So the question is, what factors should be looked for the history and examination in this particular case? Secondly, on examination, it was noticed a point on the inside vagina, probably at the episiotomy site, which is tender to touch, but there is no obvious pathology. What is your opinion about the treatment of this type of case?
Whenever a patient delivers, so when she goes home at the time of discharge, it is very important to counsel her properly when she can start her sexual relationship. So this should be a part of the routine, like how you give all the other advices to her at the time of discharge. Now they have started anyway, because immediately after delivery, for a few times, that is the time when she is feeding also, the amount of estrogen is less. And that is one low estrogen, and the dry vagina itself is one of the causes for dyspareunia post-delivery. And the other thing is that, so definitely she has had the episiotomy. Initially, when they are starting intercourse post-delivery, ask her to use lubricant gel. So if she uses the gel, even if there is less of lubrication, that friction and the pain will not come to her. So that is one thing. And if there is, with all that, and still if she is feeling the pain, whether it has been whether there is tight intritus, one thing you have to see. So post-delivery, sometimes episiotomy is sutured, and when it heals, there can be tight, intritus can become tight also. That is one thing we have to rule out. And with the examination, you are definitely feeling a tender point inside. That is the thing. So in that condition, with the lubrication, and we see whether it is healed properly. That is another thing. Whether the episiotomy has healed. Very rarely there can be a scar endometriosis. I have got cases, 1 or 2 cases of scar endometriosis, and one patient, to give an example, she had delivered outside, and then she was having pain, and each time that there was so severe pain, and even for touching and for intercourse, she went to the doctor 2-3 times, and then when she examined, there nothing was seen, and she said everything is okay, there is no need. And she was taking the nice tablets, you know that it was coming that time, nice tablets, painkiller tablet, daily 10 to 50. Each time she had pain, she used to take. She used to take in, you don't believe, 10 to 15 that painkiller tablets. And that is for 1 year. And then ultimately, then they came to me, I examined, I did the examination, thick episiotomy scar. So then I advised, so there is no point in taking the painkillers, let us explore that. So they cut open, explore it, and excise the whole scar, resuture, and she became all right. And there was scar endometriosis also in that. Scar endometriosis, any drug, it won't, as you all know, you all gynecologists, you know, very difficult to treat with the scar endometrium. Excision is the main treatment. So after that, she became so all right, and then she had another child also. That is a different story. So all these things have to be looked at, whether there is introitus, tightly it is suture, whether there is definitely, whether scar has been healed or a raw area is left out in the upper area, endometriosis is there or not, whether there is an infection. All these things have to be looked into. With all this, give a course of antibiotics, painkiller, local anesthetic. Here, if there is pain, for that pain, you can, this is one condition where you can give local anesthetic gel. And if there is any of these things, correct it. Sometimes what I have seen, when they have seen that, give on local anesthesia, 2 ml of lignocaine, the xylocaine, you inject it to the episiotomy scar. Somehow it relaxes, the pain will go off, and afterwards I have not seen any pain for it. This also I have tried. So with that itself has become given her relief, because after that, with that effect, when there is no pain 2-3 times, and there is a proper, she is able to relax, proper dilatation of the vagina occurs, then subsequently the pain disappears. This also I have seen. So these are the things with a proper history, giving a proper advice to the pregnant woman after delivery. And these are the simple things which you can see and do the simple things. That it's only as a last resort, re-exploration and then excision of the scar and resuturing. That is only as a last resort.
Ma'am, I just wanted to ask, you told in postpartum there is a low estrogen.
Yes.
Is there any role of local estrogen gel in these type of cases to decrease pain?
But except in the postmenopausal low estrogen status, I have not heard anybody using the estrogen creams to improve that. So there are also other reasons. That's why the people have not tried. I don't know. Maybe if there is a dyspareunia, definitely few cases we may try, as you said. So whether the estrogen cream can give rise to, when they come for the dyspareunia, also try that. So that can be tried, I feel.
Okay.
Yeah, but frankly, even I have never tried it.
Yes.
And in fact, this patient was my ultrasonologist's wife. So in this case, when I had just put in my finger, I could feel that area felt little different. There was like a 1 by 1 centimeter area. It was on the introitus was very patulous. There was nothing. And she was particularly saying that, when something hits it there, it is that point which pains. And you couldn't see anything except that when you felt on the wall felt little different. It was so what we did was I applied Lugol's iodine and found that area was not taking iodine well, and we did a little biopsy from that area, came out to be condyloma, and I burnt it with laser, and then she became all right with that after that. So this was very unique, actually. I've never seen anything like that.
Yes.
So just generally, I think it just came.
So that exploration and
scar endometriosis.
So that itself will give them relief.
Because, the episiotomy was very good. There was no this thing, and the vagina, the hiatus had become very lax. So there was no way. Otherwise, you could think that somebody was delivered vaginally and with okay lubrication. Why would somebody have difficulty having relations suddenly when earlier she didn't have?
Yes.
So this was very interesting. Actually, we found out condyloma, and after that, I have actually kept my antennas up for condylomas are fairly common in Indian girls because of XYZ reasons.
Is actually transmitted.
Secondly, in postpartum phase,
wants to say something.
Infection is also very, very common. I feel.
That's why a course of antibiotics and then local, because fungal infections and these things are very common. Usually we don't give oral things, only local application. Sometimes the lurking infection, a fungal infection or metrogel, and all these things, that itself can give them some relief.
Sir, yes, sir.
Yeah, I think Dr. Padmini very well covered about scar endometriosis at the site of episiotomy.
Yes.
If you cannot make out anything, do ultrasound. Something very simple. Within less than a minute, you will be able to pick up hypoechoic or anechoic area, which will show you particulate matter. You can put in a needle and try and aspirate with, say, 18 number needle, not smaller one. Blood won't come out. And you get the blood, you know that you are having a case of scar endometriosis.
Correct.
Then you can go ahead with the full treatment of this patient. I think it was very well discussed, madam.
But what ultrasounds are you saying? Transperineal or what?
No, any ultrasound, even you can do with transabdominal ultrasound if you don't have anything else. Because you don't have to have a deeper tissue. You just want to scan only 3, 4, 5 centimeters. So you can do it right from the introitus towards the end of the episiotomy.
Yeah,
you put it transversely and scan it.
Yeah.
And if you find any cavity inside which has fluid, you know probably you are looking at a scar endometriosis. It might be pus. You put in a needle. It will give you a clear idea whether you are dealing with some pus inside or is it endometriosis or collection of blood.
Right.
Thanks for and sometimes what I have seen, 1 or 2 scar endometriosis, you will not get one except one thick, only by microscopy you will see there is some changes, but only a thick fibrous tissue sometimes you will have. That also will be giving or a hypertrophied scar maybe.
Right. Hanji. So thank you so much, ma'am. Why is it not moving forward? Okay. So the next scenario is a 38-year-old school teacher comes to us with history of pain while having sex, which is of recent onset. She's been married for the last 15 years and there is no marital discord or any surgeries in either of them. On examination, she points her finger to left labia as the pain point, but the gross examination is unremarkable. How should we proceed further? Padmini ma'am.
Yes. This may be the case of the another condition, what we say vestibulodynia or vulvodynia. If you can rule out all the process of elimination, so there are no other cause for her pain, and there are no scars, erythema, or infection, all that if you rule out, and even then she has got pain, particular point only she is pointing. So that initially try with simple things, some antibiotics, gels or lubricants, local anesthetic gels. And with these things, if she is all right, okay. And try to avoid pressure on that point, a little change of the position while having the intercourse. That also you can advise her. But in spite of all that, if she is having the pain, then there are, because the vulvodynia or vestibulodynia, the clear cut, the exact reason for it is still not known. Various things, theories are described, hormone imbalance or hypersensitivity of the nerves and hyperesthesia and some neurological disturbance, immunological disturbance. All that has been described, but this is so many times the treatment becomes empirical for that. Very rarely that even similarly like some local anesthetic injection and the local application of that. With that, if the simple method, if she is all right, okay. But in spite of doing all that and the pain persists, then as a last resort, then that point, excision of the point, if it is possible, that can be tried. So that is the only thing what you can do. And check the other areas also. Usually that vestibule, even that swab test, when you are the Q-tip test about that wet swab. So with the other, the tracing of the pain in the vestibule and also in the vulva. All that in the foresight, central, and also in the vestibule, throughout the direction, in a clockwise direction. If it is, because sometimes it is in the multifocal, it is not necessarily in one point, it can also be there in the other points. But if it is only localized to that particular point in one particular area, I think with all the other things, if she is not happy or not comfortable, then probably either a local anesthetic injection or an excision. That can be done because there is nothing else, and otherwise she is okay. She was having sex also regularly. Only a flat she has developed after 15 years. So this may be a secondary thing. It's not a primary, or sometimes the provoked vulvodynia, what they describe. only with the point touching, and then during intercourse only she feels the pain.
So basically, if we don't really see anything in the external genitalia, then really we are basically ruling out all infections and everything. So clearly, vulvodynia in the clinic is very hard to treat.
Yeah, very difficult to diagnose. So many times we will be thinking of all the other things, but typical case of vulvodynia, only by process of elimination of all the other causes only we had to. But if there are particular points, so many times I have seen, even in the vagina, only one particular point they will show. That touching that point, they will get the pain.
Yes.
So that may be the typical presentation of that is a provoked vulvodynia.
Yeah, but it is very strange. Actually, this was also my patient, and again, she was a school teacher. She was very happy, you know, when I diagnosed her case and I wrote all vulvodynia. I told her, I said, go home, read on Google. But I gave her Locks ointment, and she had also again a very lax introitus. So we did some pelvic floor exercises for her. After that, she didn't come back ever. So I assume she became okay.
You must be all right. So simple things works so many times in this vulvodynia. But there are some patients really, whatever you do, they are not happy that the persistent pain, they keep on coming to you. So then,
yeah. Sometimes also women are not very forthcoming so many times in history giving and all. So you need.
They think they have to live with it. They'll just be done with that like that. It definitely reduces quality of life and anxiety and frustration to the not only to the woman, to the partner also.
Yes, ma'am. Thank you so much, ma'am.
Ma'am, since we are talking about the vulvodynia, is vulvodynia is common in premenopausal, menopausal lady or in young ladies? Because whatever cases I get about vulvodynia is a perimenopausal and menopausal ladies. And in that case,
it is a primary thing is younger age group. Primary vulvodynia from the very beginning, first time the penetration itself, from that time only they will start that pain. That is a primary thing. That is sometimes difficult to treat. And this at a later age, near the perimenopausal, menopausal, they can develop in that age also, the vulvodynia. So in the extremes of age, it is more common. So it's especially when they have got this GSM, skin conditions, other thing, something will trigger that they say that there is a hyperesthesia because of the neuronal irritation. And that also gets some hormonal imbalance, they say. So even the estrogen creams, they have tried in that. Estrogen creams for that vulvodynia. And size is also associated with that some chronic pain syndromes like fibromyalgia, that irritable bowel syndrome. So in such, you have to take the history, whether there is any other pain syndromes in her, the other things. So this also becomes a part of the overall picture in her. So then, so depending on that, you will have to treat that. But sometimes difficult, but sometimes they are mild, and with simple measures, they become all right. That also can.
Yes, ma'am.
Yes.
Vulvodynia actually has no cause. So there's no reason, but then now they're zeroing on what ma'am said is like irritation because of XYZ reason. So we have to kind of also take a big history that whatever private.
Yes, when you talked about that, see, genital hygiene
is very
you have to give them a proper instructions, wear cotton underwear and don't, because some they have the habit of douching and applying deodorants and sprays and so many things. These girls, they want to keep themselves, they think that the sense of cleanliness. So shaving and using all the creams and other things for hair remover. All these things also can lead to some of these pain syndromes in them. So this specific instruction in the genital hygiene also will help them in such conditions.
Right.
Yeah.
Very true. Since ma'am, we are talking about the perimenopausal and menopausal lady. So our next question is about the menopause only. A 57-year-old postmenopausal woman complaining of dryness, itching in her private parts, and having the painful sex. what should be our first line of approach? If this fail, what should be our next strategy? Means the first line of treatment and the second line of treatment.
Yes. So this is a postmenopausal lady having the dryness, itching, irritation, painful sex. First thing that comes to your mind is a postmenopausal, there is estrogen deficiency. So you should, even though it is postmenopausal lady and all these things, symptoms are very common symptoms of estrogen deficiency. So keep that in mind, but keep other things also in mind. So this is not the only thing. There can be other things. Rule out, then take a proper history, how it started, and then history, her health, partner's health, physical, psychological health, local conditions, any other condition along with that, because there can be so many skin conditions which can be responsible for the painful sex or the dryness and skin infections. So, and then generally history of diabetes, very important, because they can suffer from the fungal infections. So about the discharge and about the smell and other things. So this other histories also become important, taking the diabetes history, local skin conditions, because lichen sclerosis and other things. So some, they are also very common in such conditions. So the one is about the GSM menopausal symptoms. Another one is skin conditions. Another one as a part of general health condition about the sexual activity from the husband, how the partner's health is, whether there are any other comorbid conditions. Apart from all these things, whether she is on any medication. Because there are some of them also, so many of these comorbid conditions for which she is using medication, that itself can cause reduced lubrication, dry vagina, and which can again lead to painful sex. So these are simple things, or any whether she is suffering from anxiety and other things. So keep all this, her physical health, psychological health, local conditions, relationship factors, and any medication that she is taking. So you rule out all these other things, and then you can come down to this is whether it is a typical menopausal GSM syndrome or what we used to call atrophic vaginitis, and that is responsible for her conditions. So in that condition, if there are skin infections, treat the skin infections, treat the diabetes, treat the fungal infection. If she is taking any medication which is causing the dryness, so either change the medication or adjust the dosage for that. And if there are any interpersonal difficulty, and if the husband also is not, she is not able to have that proper arousal, other associated sexual dysfunctions in the female, the arousal problem if it is there, desire problem if it is there, and the husband is unable to have a proper foreplay or taking her to have a normal lubrication. All these things have to be ruled out. And in then condition, give her simple lubricants, because she is only complaining of dry vagina and itching, and whether there are any systemic symptoms of estrogen deficiency, general symptoms whether she has. If she does not have any other symptoms, it is only local symptoms, then they locally give her, tell her about the genital hygiene, give her the lubricants, simple water soluble lubricants, and during intercourse they can use that with a proper stimulation. And then definitely if she needs estrogen cream, that also can be tried. For a short course, you try it. Initially for 1 week, she can use it daily. Later reduce it to twice a week or once a week, depending on her symptoms. With the simple measures that can also help her get back her thing, because she is interested. She's only 57 years old. They have been having the sexual relationship and she complains of painful sex. That means to say we have to help her for her sexual dysfunction. So this is important. And there are so many people say why do you want to have sex at this age? I have seen some of the doctors giving that advice also. Anyway, you have finished your children, grandchildren are there, and then why should you bother? So there is no need for that. Even the husband, so many times husband comes and tells, I told that my wife, I am interested in continuing sexual relationship. But when I told my wife, she always complains of pain. and she does not cooperate. She does not even come to the doctor. So that is the difficult situation. So in that condition, a proper counseling the couple, counseling the woman, and then if they are interested to, if both of them are not, I have seen couples say postmenopausal, they have stopped having intercourse and both of them are happy. The wife says, I am not interested and there is no problem. Husband says, I am also not interested. We are happy couple and there is no need for sexual. And the other thing is, for the relationship point of view, sex is not just a penovaginal intercourse. All the other activities, being close to each other, hugging, touching, and then kissing, the simple measures are also a part of sexual activity, which they can continue. So these are all some counseling, direct counseling you can do. And they are so grateful to you that you have brought that topic and you are able to discuss with it and you are comfortable discussing. Then they come out with all their problems. So these are the things even in the postmenopausal lady. So though there are newer things which have come up and that is not available for us, if it is really a very severe form of estrogen deficiency, other things like even if there are associated systemic symptoms, hot flashes and all that, then this menopausal hormone replacement also may be necessary in such conditions. That with the history we can make out. Yeah. So anything.
So what would you say, ma'am? Do you think these energy-based devices or anything, are they doing any good in your experience?
Some of them, see, some my educated ladies who want to try all that when they want to keep themselves young, the female rejuvenation is coming in a very big way. And people are doing, we have some MCLR chairs and things like that. And it can reduce the dyspareunia, improve the vaginal epithelium and the vaginal pH and improve the circulation, vascularity. So I think in some way or the other, they're all going to help, but you have to individualize, as we said, individualize the patient, see whether she is interested. If she is not a postmenopausal woman, not interested in continuing with sexual relation, go and tell her have some vaginal rejuvenation. She will not listen. But those who are really educated, they want to try, they want to have this, because so many ladies can get married at the age of 50 years also. So they would like to continue with the sexual relationship, keep their femininity, and then improve that. Definitely, I think it has got a role by improving the vascularity and the structure, improving the epithelium and neovascularization. All these things might help them. And newer things like progesterone, DHEA, and then SERMs, which are coming up. Sometimes testosterone patches. These things are different, but some specific cases are you have to individualize and then try. When all the other things fail, simple things fail, then start using one of these things. Something or the other may work in.
Right.
How long we can use the estrogen cream? How long we can continue?
As long as the symptoms persist. Yeah, once there is a thickening of the vaginal epithelium and the proper lubrication is coming and the pain symptoms are less, you can stop. But at a later date, again, if she has again for another short period, you can use it. There is no hard and fast rule like you have to use it for a course of treatment. So initially use every day and then start reducing the number of times you are using it.
Yeah. So can I say something in that? Yeah.
Yeah, definitely.
Yeah. So the vaginal estrogen creams, essentially, we have a couple of types available worldwide. One is the conjugated estrogens that comes with the Premarin cream. That is essentially actually the most effective.
Yes.
Then the Evolon, which everybody has started to use, the estriol creams,
yes,
actually is supposed to be milder, but it's not yet FDA approved because FDA is not yet convinced of its efficacy. But of course, we use it a lot in India. And people with a uterus still should be allowed to have a yearly TBS scan to do the endometrial thickness.
Actually, they see local estrogen preparations will not have so much effect on the endometrial thickness. Then most of this, very rarely they have found out, but it is better.
Better
so if
to
you are
have.
regularly using it, it is always better because just
But if she's hysterectomized, then she can use
yeah,
without
that is
anything
okay.
forever.
Yeah.
Whatever she wants.
But if this is then this is the reason. But the uterus is there, it is always better. You see that. But this is extremely rare. They say they have seen in a very small percentage of cases where the endometrial thickness has improved. But as a routine, there is no need to add any progesterone for that, and then so that is not there. And another one I want to tell is that when we are using this estrogen cream, initially they complain of so much of burning, and they say after I applied, I got a lot of burning, I cannot use it. So slowly, small applications, and slowly when they get used to that, because it is very thin, any application probably it may irritate the vagina. Later they get used to that. And before that, if there are burning, first thing, if there is any infection, you treat the infection. Then you give the Civilan or Primarin, whatever that you are using. But other things they describe that like estrogen tablets, vaginal tablets, and estrogen ring, which can be used once in 3 months. Of those, of course, is not available with us here. But these things are described in other forms of estrogen, which is used. It must be your experience also. So many times they complain of burning. They cannot tolerate the.
Yeah, surprisingly, but then actually the method they say to start off is with you start off with a higher dose 3 months, and then you like you start with 1 gram and then reduce to 0.5 later on. But I guess it is one's experience. If a particular patient is complaining, of course you would want to reduce the dose and see how it goes.
Yes.
So yeah, HRT otherwise needs to be continued for not more than 10 years after the onset of menopause.
Yeah, yes. Till the natural menopause, that is, there is premature menopause, surgical menopause, and such conditions. So
but vaginal estrogens for the sake of just dryness and GSM, you can continue for as long as the woman wants. So that is the. So, are there any questions?
Have you any experience about Tibolone? Have you used or?
Yeah, earlier, now I don't know still whether it is available or not. It was a good drug, but again, you had to take care for a short period you can use. But it was better than other drugs and Tibolone because it had all these properties which could take care of that. Tibolone. But for some time it was available, we are all using it. But now I don't know.
I think never took up because it was so expensive. So
yes, that's why the cost factor was the one which we could not use it routinely for all.
Right. Yes. So, well, Apurva, are there any questions in the chat box or which I can help with the questions?
Lai, do you have any questions?
Lai is not there.
Rohit, do you have any question?
No, sir.
Okay. Ma'am, I just wanted to say one thing. When you are talking about this pain disorder, always we have to look after the male sex partner, because in many a time this pain, this dyspareunia or this vaginismus may have some relationship with the male sexual dysfunction.
Yes,
and
that's why secondary erectile dysfunction. That's why after you treat vaginismus and all, give some for erectogenic drugs for the man also, so that let him start getting the self-confidence. Then once they are okay with that and having a regular intercourse without any problem, then you can stop. So that is better. And any of these infections, dyspareunia, you always look into, for number one, ask about diabetic history for the male. Ask about any sexual dysfunction history in the male. So any of the infections which he has, that might have come to the wife. So that infection treatment for both, of course, everyone is doing that. So, but that in history also, the diabetes history is very important, because I have seen many cases when the wife comes with dyspareunia, pain and all that, husband is diabetic. The wife is not diabetic. So if you just test her for sugar and say there is no sugar, diabetes, anything like that, and she says my husband does not want to take treatment and then he won't take, you only give to me. And again she will come back with a reinfection. So that's how. So at that time also counseling the husband, giving him the treatment also becomes very important.
Yeah. Actually, I recently attended a webinar by this International Society of Vulvovaginal Disorders. And they emphasized on two things throughout the lecture, which they said that very important for all gynecologists to first do a vaginal pH. We all feel, oh, it is looking like a fungus, it is looking like whatever bacterial vaginosis, or it is looking like a chlamydia. We never do the testing. We don't even do the slides, which
just a dip test, they do that simple test of
we have the pH. This strip is available in the OPD, and whenever there is a doubt, we should use that.
No, it is not doubt, Apurva. It is said that, they said, I was shocked actually to hear that lecture, which they said.
Typically for bacterial vaginosis, that is one of the symptoms or one of the indication or to diagnose bacterial vaginosis, this pH measurement becomes important.
And they said if you just see and treat, you only can treat up to only 30% patients correctly, which I was so surprised that we are so confident of our diagnosis all the time. We feel what I have said is okay. I feel it is looking like chlamydia. I feel it is looking like bacterial vaginosis. So we feel we are 100% of the time correct. But they did a very large data they had presented, which they said that on an average, gynecologists are correct only 30% of the time. That is why we are getting so much resistance because we are not sure of our diagnosis, so we will give antifungal also, we will give clindamycin also, we will give all steroid creams also, because we are not sure what's happening. So we just want the patient to get all right. So then next time she'll come, we'll give stronger zoles and stronger steroids. Yes. So first is very important.
And what I feel, ma'am, the bacterial vaginosis is nowadays in a rising trend, and it's all due to the douching, due to the extra, different type of ointment, different type of deodorant, what they are using. So even I have seen that starting from the menstruate at a 13-year of age, they are using all those pH control. They are very fascinating with those advertisement.
Deodorant sprays, they use it very much.
And these actually disturb the total vaginal flora, and the patient usually land up into the bacterial vaginosis. Yes. So this is, I think, it's a rising trend. Previously, it's due to the chlamydia and already because due to not using the proper, pads and all. Nowadays, I think bacterial vaginosis are at an increasing trend.
Yeah, because of the change in the pH itself, they're prone for infections. So that's how it is causing the infection. So that younger girls are coming with all this so much of pain, burning, irritation, and itching irritation. And so many ointments here, throughout the year they will have used. And I asked them to stop all the local applications. Then they become all right. Only give some systemic tablets. Stop all the local applications, they will become all right. And the other thing is because the jeans pant and all they use, and because daily they think they cannot wash it, such a thick material and all that, so they keep using it, reusing the same thing. So I make it a point, if you are using jeans pant and other thing, first thing every day, make it as soon as you wear, you make it a habit to wash it, and don't reuse it without washing. So certain things look simple, but specific instructions in these things will definitely help them, because more and more young girls are coming with infections, lot of vaginal vulval infections. So it should not happen actually, young girls, and not exposed to sexual relationship also. It's very common.
I don't know, what is your experience, ma'am? Is the normal Indian population getting more promiscuous, or they're just getting more bold to come to the doctors?
Yeah, both ways. A little more awareness, and college students and young girls, they come. And the mothers also will bring the girls. So she is having itching. And sometimes I have so many courses of treatments they need, and still they are not with one course of antifungal or antitrichomonas and all that. Earlier, we used to tell trichomonas and all that fungal will come after marriage. And so nowadays I am seeing in adolescent girls, many girls, they come with infections.
Yeah, overeating also. Sugar. Sugar.
Obesity, sweating, the sweating itself is under tight jeans pants and the nylon underwears that can cause sweating. That itself can lead to fungal infections.
Right.
That is also another reason. Like that.
Neeraj sir, what are your take-home messages?
Yes, it was very nice. Thank you, Padmini Madam. It was a very practical points you have covered of each and every cases. So that was the aim of our this series, because we want some practical tips how to manage this, and you covered it very well and very well moderated by you, Dr. Seema and Dr. Apurva. Wonderful moderators as always. Thank you very much.
Good cases, good selection of cases which could cover
Yes,
all varieties.
All credits to Seema ma'am.
Thank you so much, ma'am. Thank you. Really, it is, we like, I am actually branching out. So sometimes, we get, we theoretically we start thinking of it could be this. I mean, you are so perfect, such natural flow of thought that, everything comes up so well, and, and you don't seem to miss anything. It's like,
yeah. And ma'am, the first is the first question. When there is only one finger inserted, we are thinking, when I got this question, I was thinking, no, this should be like this should be like this. And ma'am, you have done this like so well. My goodness. Thank you so much. Really.
Good teacher is always making everything so simple.
You made it such a nice interactive things. You all made it. So it is nice to discuss practical points, because that's what will help us gynecologists here. So we all know theory, and anywhere you get that, and then just listing out, you can give this, that does not help. Actually, what you can do, such things. So that will definitely help you how to go about things.
Yeah. Dr. can you just be with?
Apurva, now you can have a vote of thanks.
Yeah, okay. So after this wonderful and practical session, why I am talking this as a practical, because we are not sharing any slides, and we are getting the real life questions, and we are discussing these from teenage to menopause about the genitopelvic in penetration disorder. So after this wonderful webinar, is the time to say goodbye to all of you from 2021. This is our last webinar 2021. But yes, we will
happy New Year to you all. Happy New Year.
And we will definitely come back with some very interesting and very informative webinars with the faculties like Padmini ma'am, definitely. So it's the time to say vote of thanks. I am really thankful to none other than but the Foxy President, Dr. Shanta Kumari ma'am, the Secretary General, Dr. Madhuri Patel ma'am, the Vice President in charge, Dr. Bipin Pandit sir, none other than the person behind all this, the chairperson of our committee, Neeraj Jadhav sir, the chief guest for today, Dr. P.K. Shah sir, the guest of honor for today, Dr. Parag sir, Parag Diniwale sir, the faculty for today, the very gorgeous, our own Dr. Padmini Prasad ma'am, our wonderful moderator, and my senior, my very good friend, Dr. Seema Sharma ma'am, and the ICOG chairperson, Dr. Uday Thanewala sir, and the secretary, Dr. Ashok Kumar sir, and last but not the least, all the viewers and the Intas Pharma, the Rohit, Alay, for giving us this platform and making this a wonderful webinar. Thank you so much.
But not the least, Apurva.
Thank you so much.
Apurva also. So
yes.
Dr. Neeraj Jadhav will come with the newer things in the new year.
Yeah.
Lined up, newer things lined up in the new year.
Yes.
Yes.
So thank you so much.
You.
Happy New Year, everybody.
See you all in Indore, definitely.
Yes.
We will rock. And Seema ma'am, a happy birthday in advance.
Oh, thank you so much.
Happy New Year and happy
Ma'am's birthday in the 1st of January. So we'll get treat in Indore.
Yeah.
Sure.
Bring cake to Indore.
Sure, sure. Thank you so much. Good night.
Thank you. Good night to you all.
Thank you so much. Thank you so much.